with Healthstyle, the new health and wellbeing podcast from Kingsbridge Healthcare Group, which comprises Kingsbridge Private Hospitals in Belfast and Sligo, Kingsbridge Eye and Hearing Centre and Kingsbridge Training Academy. My name is Avril Keys and I'll be hosting this series of podcasts, putting real patient questions to the medical team at the hospital. From diagnostics through to treatment, we'll give you the lowdown on what to watch out for and when you should make an appointment. This week's topic is a personal one for me, and in fact it kind of inspired this series of podcasts. For the past 12 years I've suffered with episodical back pain due to bulging discs. It happens every 3 to 4 years and takes upwards of 9 months to settle. March 2020 saw the issue arise again, and by August I was on 27 tablets a day and pretty desperate. So following an MRI at Kingsbridge, I had my first consult with Mr Nikolay Peev at Kingsbridge Lisburn Road. So I'm pretty active on Instagram, as I've been blogging for over a decade, and what I became aware of is how many other people were in the same boat. I found myself deluged with messages from fellow back pain and sciatica sufferers, and a common theme was that many didn't know where to turn, especially with lockdown. Okay, so fast forward a few months, I'm thankfully well again and pain-free, but still getting all the questions about back pain. So I suggested to Kingsbridge that I create some useful content around the issue, perhaps via podcast. And this is it. And the great news is that there will be more, because back pain is not the only thing that we're all hungry to know more about. So looking forward to covering issues like menopause and urinary health, and also to having a couple of recordings with the Kingsbridge GPs. So today is all about backs, and I am delighted to have my own consultant, Mr Nikolay Peev, MD, PhD, neurosurgery and a fellow of the Royal College of Surgeons. Mr Peev is a consultant neurosurgeon and spinal surgeon, and he's got a wide remit, including spinal trauma, brain injury and neuro-oncology. But today we're focusing on back pain and the kind of medical procedures that can transform people's chronic pain. So welcome, Nikolay.
Thank you. Pleasure being with you.
I've had lots of questions sent to me, so tried to distill them here. One thing I noticed was there's lots of different terminology in terms of describing the bulging discs. So I've heard people talk about bulging, prolapse, herniation, slip disc, and their terms seem to be used interchangeable. Are they the same thing effectively?
Well, these are basically representing different stages of the development of a disc herniation. It can start with a small bulge, and then it continues with protrusion, then goes bigger and becomes extrusion, and then it can migrate up and down. So these are all stages of development of one and the same disease.
Okay, I understand. So, and is disc degeneration then a different thing? Is it always connected?
Yeah, it usually starts with disc degeneration. Initially, I usually show that to my patients. I show them this model, for example, and I show them the MRI scan, and then they can better understand what are we talking about. So I show them that, for example, some of the discs are nice and juicy looking, but then you see some of the discs are getting black, and you can read in the internet a lot about black disc disease. This is normally the initial stage of degeneration, and then this can progress or cannot, or may stay in the same stage. But if it progresses, that will normally give you collapse of the disc, disc bulge, disc protrusion. Then the worst case scenario, that disc can go out and can start create problems.
Yes. And what are the underlying causes of all of this?
Right. Okay. So it's a very complex question, and we can talk about that until tomorrow, maybe even further.
Okay. Well, do me the brief answer.
So to cut it short, of course, there is genetic predisposition, because some people are struggling with that, some people are not. They are just healthy aging. But if we do a scan and we see different things, that not necessarily means that the patient is struggling. So there is such thing like healthy aging. So you see some different wear and tear changes, but the patient is all right. Yeah. But on the other hand, there is patients which are struggling with that. And although we say that only about maybe 3-4% of these patients will be operated, still the statistics say that this is the second most common problem after the flu. So people are getting to see their GPs for flu symptoms, and then the second one is issues with back and pain. So degeneration is very, very widely spread and very common, and the reasons are genetic. It could be unhealthy lifestyle. It could be not proper ergonomic position at work. It could be physical overload. So, for example, it is good that you have to go and do your training. You have to be active, but if you're doing it so much, that can also harm you.
Yeah. Okay.
So complex reasons.
Yes. And I think I remember you saying to me that you could MRI a number of people at the same age as I am and see a similar presentation, but it doesn't always result in pain.
Yeah, that's correct. So that's what I said. There is such thing like healthy aging, and maybe about 95-6% of people which are having MRI changes, they don't have problems. Yeah. And they are just aging healthy.
And it could also be potentially the makeup of your body. So, in terms of, I guess I was coming on to talk about that the bulging disc is not necessarily the problem, and certainly wasn't necessarily for me. It was the fact that it was impinging a nerve. So, were my nerves closer to my disc than other people?
Correct. Yeah. So, exactly. So there is people which have big discs and bulges, and that's not a problem for them. So again, as you said, this is how your body is built. So with some people, I see on MRI scan very narrow spinal canal, and then even a small bulge may cause severe problems and symptoms. And on the other hand, I see people which are constitutionally having a large canal and even a big bulge that is completely pain-free. So it's genetics.
It's amazing. It really is. And I suppose the maintenance and management of the condition, I suppose initially, so many of us will have, achy backs or maybe a little bit of a sciatic pain. So should you keep moving, exercising? When should you rest and start taking painkillers, or even consider coming to someone like you?
Right. So the short answer is, in general, yes. You have to keep yourself fit even if you have symptoms. There is conditions which you can harm yourself further in case you keep exercising. And the first thing that we have to mention is a cauda equina. Pretty much everybody that has back pain or back symptoms has heard about this cauda equina problem and symptoms. This is when you really have bilateral problems with both of your legs, numbness, pain. If you struggle with your bowel and bladder function, then this is something serious that you have to stop. You have to go immediately see a specialist and discuss or have MRI scan or different imaging. But this is one of the few conditions where you can actually harm yourself if you continue. But with everything else, most often we see patients with different stages of degeneration, which are mild or moderate, sometimes even severe. But I still recommend to these people, be active, try to do some yoga, try to do some stretching, try to do Pilates. If you cannot run or walk, as many people with back problems can't, because this is giving them further pain, go on a bike. Bike is something really good for your core muscles, and that keeps you fit. So be active. So
keep moving, yes. And you certainly said that to me when I come in. And I guess it's keeping active within a relative, or I suppose a manageable pain level, not pushing yourself to a point where you're much worse pain-wise.
That's always good to consider. Yeah. So you should not be pushing yourself so much. So if you're really a tough guy, you may think that today you can push yourself and do a lot, but then for sure you will pay. It will pay tomorrow. So you have to push yourself a little bit, but don't overdo it.
Yeah. And so I think in my case I probably did, because between March and coming to see you in August, it was a case of wanting to keep moving and knowing the importance of that, but actually pushing too hard at the time. But you live and learn.
I think the right approach is listen to your body. Try to do every day. Try to do a little bit more than you did yesterday. But on the other hand, don't be pushing too hard.
Yeah. And I suppose I've heard you talk about kind of different stages of treating your back issues. So So I guess if you take the very initial stages where you've got this pain, it's presented, you're feeling quite uncomfortable and a bit restricted in what you can do day to day. So what is that first step? It's obviously not to come to you first. What would the first step be that people should take when they feel a pain coming on?
So of course, if the pain is not so severe and if the symptoms are mild or moderate, the patients can try to see their GP. They try, usually that happens, they go and try to get some medication. There is different medications which are over the counter. You can buy them in Sainsbury or in Tesco or in the major supermarkets, and you don't need even prescription for that. So you can try that. You can try to keep yourself active. As I said, you can try to do some stretching. You can try to rethink, just stop and think and analyze your life and see what is giving you your pain. See if that's that running that you do every day, and after that running you feel very bad. So obviously if that's the case, then you have to stop running and you have to replace it with something else. Or if you do your 5-mile walk, and if after that 5-mile walk next day you struggle, obviously you have to reduce that. Try change your physical activities, but don't stop. Try to help yourself first. Try to live a little bit healthier, and then if that's not helping, then obviously you have to go and see somebody and take advice.
Yeah, and would you recommend physio at that point as well?
Physio is always a good start because there is significant portion of these back problems that will settle within 6 to 12 weeks, and that's why we recommend. Don't jump into major conclusions initially. Try to manage your pain. Try to go through these maybe 6 weeks at least before you really consider major options. That's what, even if I see patients in that period, I normally, if the problem is not so big and so severe, I advise them, go to your physio, try to just tweak some medications. Of course, there is severe problems and very symptomatic patients which you really can't send them away even if it's in these 6 weeks. So you still may consider seeing specialists in case your problems are so bad and you can't cope. That's also an
so option. It's a good thing to let the body try and heal itself, say within that sort of six weeks.
If
and maybe
that's
out
possible,
to 12,
yes. If that's possible, yes, that's good.
And then I guess the next step. So for me, the next step was to come to you, but I did have an MRI before I came to you. So is that the better way to do it, to have your MRI first before making an appointment?
Certainly, if you come to me with a back problem or with any spinal problem without any imaging, I will investigate you. I will examine everything that I can in the treatment room, and I'll see if there is any red flags that really will make me to rush you in the MRI scanner and organize for you things as soon as possible. But if that's not the case, which is happening quite often, I will send you for an MRI scan or any other appropriate investigations, and then you will have to come and see me after that. So in case you can get your MRI scan beforehand, that's not good. That's not bad.
That's good. And then the next stage, I suppose, again, we talked about these 3 stages. So if you've done the sort of physio painkiller route and you're not getting anywhere and we're potentially more than 12 weeks in, then the next stage, am I right in saying, would be an injection?
Yeah, so the injection is alternative, and that comes before surgery for many of my patients. So the injection is a good modality that will give you. I tell my patients that this is your window of opportunity. So you come, I will inject, and then you will probably have some relief of your symptoms, and then you have to use that as a window of opportunity. You have to try to mobilize yourself a bit more. You have to go and see your physio again. You have to tweak your medications, and there is a good chance that you will get away without any major options like surgery. Yeah.
So it's not going to fix the situation. It just gives
there is patients which will benefit from injections so well that they will just come and say, I'm well, I don't need you, and then that's it. We leave it there. And it could be for years. It could never happen again. So that's also an option. Unfortunately, we cannot predict how many of these patients will have good outcome from the injection. Obviously, if I see a major problem on MRI scan, I might just skip that injection. I say, really, there is no point for you to waste your time. You have to go and have surgery. But with the majority of the problems, injection could be a viable option.
Yeah. And are there different types of injections? Because when I had mine, people were asking me, what is it, a spinal block? Is it a nerve root injection? And I actually didn't really know. I just trusted you to do the right one.
So in general, the injections are steroid injections. So we apply solution that is steroid mixed with some local anesthetic. And like that, we chase immediate effect from the local anesthetic and the steroid to stabilize that effect and to give long-term effect.
Okay.
And we install that, we inject that steroid and anesthetic mixture in different places. Depends on what is your pathology. So yes, it could be facet joint injection, which will be applied at the back of the spine where the joints are moving, and that gives you back pain. Or we can inject close to these yellow roots that you see there on the scan, that on the model, that is the nerves that go to your legs or to your arms and everywhere else in your body. So we can inject a specific nerve that is trapped by a disc or something that will reduce your arm pain or your leg pain. Yeah. So there is different types of injections.
So it's tailored for each customer.
Based on your symptoms, based on your MRI scan, based on what you say.
And it was an interesting procedure to go through, because I think when I thought of injection, I was thinking like a vaccination, but it's quite a procedure. I mean, it's done with full X-ray in the operating theatre, and it was more than I expected.
Yeah, well, we have to do it precisely. So the idea of that injection is that we are possible to deliver a very high dose of the steroid locally, exactly where it's needed. And like that, you avoid having complications and the side effects of the steroid, because the corticosteroids, they're dangerous drugs. They can give you side effects if they are on a high concentration in your body. But with the injection, we apply locally high dose, but we don't deliver high dose to your body. So that's the effect of it, and that's why we have to do it in special settings. You need a theater, you need an X-ray. I need to see exactly where is the tip of my needle, so I do it properly.
Yes, and I had lovely support around me as well. I was so grateful for the nurses there who held my hand throughout.
We have a great team now, and we are very experienced, and we do injections on a regular basis, and it's working very well.
And could people have potentially more than one injection then over a long period of time to keep their pain at bay for longer?
Right. So the answer of that is yes and no.
Okay.
So at the minute, the recommendations for the injections are that you really don't go and do it on a regular basis. If you, however, for some reason cannot have surgery, let's say you have symptoms that are persistent, you come and have your injection, you get relief for a period of time, and for some reason your symptoms come back after, let's say, 3, 4, 5, 6 months, and the options are go and do another injection or go and do surgery. So most often I will recommend, if there is the alternative of doing multiple injections or do surgery, in case it's a young man, active man, then I will probably recommend surgery, because that is now the strategy that is followed nationwide, and this is how the NICE guidelines is recommending. Okay. However, if for some reason you cannot have surgery, say health issues or advanced stage, you still can have multiple injections, and you can have good result, and you can control your pain, and you can have good quality of life. Or for example, you have that injection, and then after a few years you have the same problem, then that's a new episode. You can have another injection.
True. That's not a problem. And so I suppose that brings us nicely on to the surgery, and you had identified me as a good candidate for the minimally invasive spinal surgery, and that was the first time I'd ever heard that kind of surgery discussed, because it traditionally was more of it cut through the muscle in the back with a significant recovery period. And you explained the surgery to me really well using this model. So I suppose can you tell us this? Is it quite a new procedure, and how does it differ, and how is it better for patients than maybe the older style operation, which involved cutting through the back?
Yeah, so probably most of people which are with us now, they probably have read or heard about a keyhole procedure. So actually many patients are asking me, are you doing keyhole procedures? So that's shortly said minimally invasive spinal surgery procedure. You can say keyhole. So most of the surgical specialties now are progressing towards this minimally invasive surgery, and the reason is now the technology and the knowledge is allowing us to do the same operation that we used to do with the classic large openings, to do it via literally keyhole. And of course this is better because if you think about surgery as a general principle, what do you do with surgery? You split the body, you go deeply there, you find the target, you do the surgery, and then you have to restore these tissues. But whatever restoration you do, even if we restore following the rules, that's never going to be the same. Your muscles, for example, in the spine is detached from your spine, and that's it. They will never be the same. They're going to be replaced with scar tissue. And that scar tissue is just inactive, and then this is going to promote more degeneration in the future. So that's what we are doing with the keyhole surgery. We are trying to minimize the impact of the surgery. And this is the beauty of it, and that results normally in a faster recovery for these people, less complications. For example, when I do minimally invasive, I don't remember when was my last infection, so I don't have, my infection rate significantly dropped after I started doing minimal invasive.
That's interesting. And obviously, because I think when you hear the word back surgery, you just think it's going to be really massive and impactful in your life. And when you described it to me, it just seemed like such a very straightforward op for you to do, and you clearly do quite a number of these. I
quite often hear in my consulting room, I'm afraid of spinal surgery because I don't want to get paralyzed. I honestly don't know where is that coming from. Maybe this was the case 30, 40 years ago, but now luckily and thankfully I haven't even heard of anybody around me in my hands or in my colleagues' hands being paralyzed after relatively simple surgery. Of course, there is very rare, very, very heavy duty surgeries which can carry significant risks, but most of the, maybe 95% of the surgeries that we do are for minor to moderate degenerative problems, and this is not happening.
Yeah. And it does, I suppose one of the things that I had held off with surgery was I thought, if I have it now, do I then limit my options in the future? And should I try and recover by myself now and keep the operation as that option to have then when I am older? But does that apply anymore?
Very good question. So again, the answer of that question is yes and no. So if you are healthy, young, and if you have some minor or moderate problem, and if you're thinking about surgery, of course the advice is try to push that surgery as far away as possible, if possible. And then the answer no comes. So if you're young and healthy and active person and you're severely disabled because of your condition, you want your life back, so you have to consider surgery. So if you are persisting with the conservative treatment, physiotherapy, medication, injections and all that for 3-6 months, and if you're not winning, then obviously if you would like to have your life back, you have to consider something else. And then there is another thing that you have to consider, that if you keep that pain there for a long period of time, that pain may chronify, and even if you start thinking of surgery, let's say 1 or 2 years down the line, the options may be limited comparing to what it had been when it started.
Okay. And I take it, though, that you only have so much in the disc that you can slice off. So what are the options if, say, the problem recurs? You can't obviously keep trimming that disc. So what would the next step be from a surgical point of view?
There is a big variety of options now that we have for degenerating discs. So we start with a very small, very limited, very minimalistic options. Like we start with injections. Obviously, we can inject and we can try to settle the pain and settle the symptoms. Then, if things are not working, then we do a very limited, precise keyhole decompressions that can free some space for the nerve. If that recurs, then obviously we have to go further. We have to decompress more. And as you said, there is a limited amount of disc that can come out, and after that, there is a point where we have to replace the disc completely. Yeah. And there is options. We can now replace the disc with artificial discs, for example. Yeah. We started doing that in cervical, in the neck region in Kingsbridge, and we are having good results. So there is a big variety of options, and that depends on what is your condition and what is your MRI scan looking, and what are your symptoms, and so that's been tailored approach.
And I'd heard about these artificial discs, and it certainly gave me good hope for the future in case I have to go down that route.
Yes, so there is the technology. Luckily, the technology is developing pretty fast, actually, and there is constantly new options which are coming, and they are better and better, and there is options.
Is it can it be done with a lumbar spine?
It can be done in lumbar spine, but there was a big enthusiasm about lumbar spine maybe 10 years ago, but unlike the cervical spine, where you don't really need to open so much, you go through the front of your neck, but it's very easy to do that. Comparing to lumbar spine, where you can go through your tummy and you have to move all this, and it's associated with a lot of morbidity and a lot of complications. So it was a big thing in Europe and in Germany, and some people tried here maybe 5-6 years ago, and then we got disappointed, and now we don't do it much. But for the cervical, for the neck, it's a different business. It's a very successful there, and there is now new devices which look like the normal disc. And I have done probably now about maybe about 20. So I remember I was invited as faculty in Spine Masters in Turkey in 2013, and they asked me to talk about artificial disc. And I have delivered a topic why I don't do artificial disc. But see me now, I've started doing it because the technology is developing. Now the artificial disc is into NICE guidelines as well. It's been even decommissioned as something that is not very complex and very difficult to do. So even now the general pool of surgeons is accepting that as something normal and something that we have to consider for somebody who is below 65, for example.
So I suppose one thing just to bring it back to, because I know you'd mentioned it to me when we met, was that the surgery is a lot to do with nerve impingement and freeing up, like you say, the spinal canal. It doesn't guarantee that you'll be free of back pain. And is it the case that people quite often would still have back pain despite having had these surgeries?
That's a very good question. So we are living now in the era of information that is streaming from everywhere. Now we have social media. We are doing one of these now. So people are having a lot of information about this. And that's on one hand. On the other hand, the demand that people are having is more and more. So I see now older patients which come and see me, and they say, I see 60, 70, and they come and see me and they ask, can you do keyhole surgery for me because I still want to do marathons? And there is nothing wrong with that. But what I mean is, comparing like 20 years ago, people had a bit more modest expectations, but now this is not the case. And again, there is nothing wrong with that, because now we have way more options, and we can offer that, and we can keep people going. That's on one hand. So I'm happy to consider I don't like if somebody tells me, "Oh, am I too old for surgery?" And I say, "No, that's the age is just a number. It depends how you look, if you're healthy, if you're fit. Why not?" On one hand, but on the other hand, yes. You still have to have proper expectations. I normally say to my patients, I'm warning them that I'm just a simple doctor and I cannot, let's say if somebody is 60 and I have to operate him, I warn him, I cannot send you back to your 20s. That's not possible. So sometimes I say the goal of the surgery is to make you better, but not to make you perfect. Yeah. So yes, if we have multi-level wear and tear, if we have a lot of degeneration, we normally try to pinpoint one disc or couple of discs which are generating the majority of the problems, and we address that. But we cannot replace the whole spine. So after the surgery, there still might be symptoms.
Yes.
But if they are minor or manageable, then we should be happy with that.
Yeah. And I suppose that's a good way to finish today, I guess, in terms of all of us do probably need to manage our expectations. We're all trying to do things that we did happily 10 years ago. And I suppose, would you have some general pieces of advice in terms of just managing a healthy spine and back and trying to maybe postpone some of the issues that you might have maybe into the future?
Well, I always say to my patients, be fit, be active, be healthy, and that is the general formula for postponing your problems. Putting on weight is one of the things that will be detrimental for your spine. I always tell them that region, the lumbar region where the majority of the problems happen, this is your center of your gravity. So every step that you do is loading that region with 2.5 your body weight. So if you're, let's say, easy calculation, if you're 100 kilos, every step that you do is loading that region 250 kilos. And put it the other way around. If you lose 1 kilo, you're offloading there 2.5. So be healthy, be fit, don't put on weight.
Yes. And any particular exercise to avoid or to do more of?
If you have lumbar spine problems, where is the majority of the problems? I normally don't recommend running. Walking with moderation, cycling, do as much as you can.
Yeah. Thank you very much, Dr. Nikolay. It's been really great talking to you today.
Pleasure.